Hello and welcome to this Pro CE podcast. I'm your host, Kim Neely. Today's episode features a discussion on collaborative care and engaging patients with nonvalvular atrial fibrillation in shared decision-making. This episode is part of a larger educational program titled An Untapped Resource, Pharmacists' Role in Improving Screening and Management of NVAF. During this episode, Dr. Kathleen Lusk from the University of the Incarnate Feik School of Pharmacy will provide recommendations for collaborative care, patient engagement, reducing health disparities, and improving medication access and adherence in the management of nonvalvular atrial fibrillation. For more information on Dr. Lusk, along with CE-certified microlearning modules with downloadable slide sets, a clinical thought commentary, and a downloadable infographic reference guide, please visit the show notes for this episode. Now let's get started to hear what Dr. Lusk has to say on this important topic.
We'll start with tips that we have on how to enhance patient engagement and patient education. We can't begin counseling our patients or educating our patients or communicating with them until we first identify potential barriers that we need to circumvent in order to effectively communicate. There are various types of barriers that can be present in the day-to-day practice of a pharmacist, and they're broken down by the type of barriers that are present. First, we can start with the pharmacist-centered barriers. These are things that as a pharmacist, we personally can't intervene on or affect in the decisions that we make on how to interact with our patients. First, we must consider our body positioning. It's not uncommon for pharmacists to have a very heavy workload, be very stressed. Sometimes our body positioning can be very closed. We might have folded arms. We may not make great eye contact. So we may not have a really open, welcoming experience for the patient. This kind of goes into our nonverbal communications as well. So are there things, like I said, the crossed arms, not making eye contact, or being distracted by phones ringing or the computers surrounding us that don't allow us to directly connect with our patient? Additionally, we need to be very cognizant of our voice or tone. When we're working in very stressful environments, as pharmacists are often required to do, we need to ensure that we don't have a rushed feeling or a frustrated tone when we're speaking with our patients, as it will make them less likely to open up to us and less likely to seek our opinions and our help. Looking at environmental barriers, these are going to be very much dependent on the practice site that you're working in. Things like the pharmacy counter, although they are meant to be welcoming places for pharmacy patients to come up to, they can actually provide a physical divide between the pharmacist and the patient that can be a bit off-putting to patients. Additionally, depending on where that pharmacy counter is located and where the counseling counter is located, it may not provide adequate privacy for a patient. And if we don't provide a safe location where patients feel like they can share their personal information without it being overheard by people surrounding them, they may be very hesitant to ask questions, or they may be very concerned about sharing specific personal details. And then finally, as I mentioned before, workload is very challenging for pharmacists these days. Pharmacists are pulled in so many directions with filling prescriptions, medication therapy management, various interactions with other healthcare providers, being on the phone and on our computers, as well as providing vaccinations really year-round now, that it can be very challenging for us to build in adequate time to counsel our patients and educate our patients. Finally, we have to look at patient-centered barriers that can be of concern. The first and one of the most obvious ones is, what is the language that the patient prefers and what is the language that the pharmacist is comfortable speaking? So if there is a dissonance or a disconnect there, we need to be cognizant of that and use the translative services as available. Additionally, what is the patient's ability to hear us? If they're hard of hearing, again, we might need to be louder in how we speak to them. But that then goes back to a lack of privacy. If we are shouting information at a patient so they can hear us, that limits that that increases that environmental barrier of that lack of privacy. Additionally, something that is so vital, especially in 2022, is this health literacy assessment. So it's very important that we screen our patients for their health literacy and determine what is the optimal way to educate the patient. Perhaps verbal instruction is not ideal for the patient. Same with written instructions. We might have to get creative in how we're sharing information with our patients. And then finally, we have to be cognizant of past experiences that a patient may have. They may have a negative connotation of pharmacists or a negative connotation of healthcare providers based off of bad experiences they've had in the past. Once we've identified barriers and made efforts to remedy those, we can use a variety of different methods to really enhance how well we can counsel and educate our patients. One of the main ones that I highly suggest is the use of motivational interviewing. Motivational interviewing is a very effective approach that is a patient-centered approach to identifying what motivates our patient to want to be successful and to take charge of their healthcare. We want to identify what is their intrinsic motivating factors to change their current behavior or their current status of health. We want to focus in on identifying any conflicting behaviors or conflicting concerns that a patient might have and try to remedy that ambivalence. We want to strive to discover where is the patient at right now and bring ourselves to their level and to their understanding. We want to figure out why are they not making the changes necessary to reach their healthcare goals. And it's important that we develop a mutual understanding between pharmacist and patient. So we don't want to take an approach of, I'm the pharmacist, I'm the expert, this is what you have to do. No one wants to be dictated at. Rather, let's take a collaborative approach and say, this is my opinion. This is what I would recommend weighing the risk versus the benefits of a specific treatment. Where are you at? What are your thoughts? And bridging those gaps as necessary. We want to also then empower the patient to make the change themselves and give them the support they need to feel like they can make the change. If patients are empowered and feel like they're taking charge of their own care, they're much more likely to reach their healthcare goals. There are various components to motivational interviewing that can help it become successful. The first and one of the most important things is the use of open-ended questions. Open-ended questions allow us to facilitate discussion with our patients and allow us to really solicit the necessary details we need to figure out why the patient is the way they is or why the situation is how it currently is. Additionally, we want to focus in on use of affirmation. So we don't want this to be a judgmental interaction with the patient, but rather we want the patient to know that we are here to support them from start to finish and everywhere along the way. We want to be an active listener and a reflective listener when we're speaking with our patients. So we may need to repeat things back to them, provide summary statements to say, this is what I'm hearing that you're saying. Am I understanding what you're sharing? We never want to assume we know what they mean or assume how they're feeling without verifying that from the patient first. The next thing that we do with our motivational interviewing is figuring out, is the patient ready to change? And if so, at what stage of change are they? So this table provides an overview of the 5 stages of change, from pre-contemplation, meaning the patient is not interested in change, they have no desire to make any updates to their lifestyle, to the action phase where they are ready to hit the ground running, to make large changes to help themselves feel better, to meet their healthcare goals. How we approach a patient is going to be very different depending on what aspect or what readiness of change they are. If they are in that pre-contemplation stage, us being very dictatorial or us being very aggressive with telling them they must change, they must make these updates to their life, they must take these medicines, is not going to be successful. Rather, we could perhaps take a step back and not push quite as hard and say, let's provide you with some information that you can contemplate over the next few days to weeks. And then set a time for follow-up so that the patient knows that we will be checking back in with them to reevaluate their readiness to change or to follow up with questions that they may have moving forward. Motivational interviewing can be broken down by a variety of principles, which are provided for you here on the slide. And we'll dive into them one by one here moving forward. The first 3 principles really flow into one another. These include avoiding argumentation, expressing empathy, and rolling with resistance. So again, this goes back to that creating a very warm, welcoming, collaborative environment with our patients. We want to avoid confrontation and avoid argument. We want to, if we come to a position where we are sharing our thoughts with a patient and they're becoming resistant or they're becoming defensive, rather than becoming defensive back at them or forcing our opinions on them, that's when we take a step back and make an effort to empathize. Put yourself in your patient's shoes as you're able and figure out where is that hesitation coming from? Use that reflective listening to say, here's what I'm understanding basing on what you're telling me. This seems to be a barrier that you are working through right now. And then using that to help the patient identify ways that they can move forward to perhaps eventually get to taking a specific treatment, being more effective with lifestyle changes, so on and so forth. Additionally, we want to move with our patient, our roll with resistance, meaning, again, don't fight back the resistance the patient's pushing forward, but rather explore where that resistance is stemming from. We can't fix the resistance until we understand why the resistance is even present. Next, we want to develop discrepancy. So this is where we take that gentle, non-judgmental, confrontational approach with a patient. And that seems a little counterintuitive or a little bit Like I'm saying two different things, but let's delve into it a little bit. This is where we as pharmacists have to balance our assertive nature of wanting to help patients understand why they need specific medicines or why they need specific treatments, but also maintaining a very sincere, honest, and open discussion so we can figure out, are they understanding the necessity of each of these treatments? And if they're struggling with not understanding, how can we help them? Oftentimes, patients are not aware of a disconnect that might be present in their life that are preventing them from reaching their goals. And let's look at a few examples of what that might look like. So the patient's goal might be, I want to live long enough to see my grandchildren grow up and I want to live independently. But we look at the patient's behavior and they're not adherent to their medications, including their anticoagulant, which they're perhaps using for their nonvalvular atrial fibrillation. The discrepancy here is by not taking that anticoagulant, they may have a stroke, which will not allow them to live long enough to see their grandkids grow up. Or perhaps they survived the stroke, but now have to be in an assisted living facility or a nursing home. Another option or another goal or example would be the patient says, I don't want to have to be in the hospital anymore for my heart failure. When we ask the patient about their diet and about their exercise, they say, oh, I eat a lot of fat, I eat a lot of foods with sodium in them, and I hate to exercise. And as we know as pharmacists, all of those poor dietary and lifestyle choices are increasing the risk that heart failure will be exacerbated. So here it's our job to take a step back and say, the patient is making less than ideal choices in regards to how they're behaving and how they are living at home in regards to these disease states that they're having. And instead of dictating to them to say, you just need to take your anticoagulant, you need to stop eating so much salt, is maybe describe to them, why do they even need an anticoagulant? What is the purpose of this blood thinner? To help them understand what is going on in their body when they have atrial fibrillation. Why do we need a blood thinner? Because if they have a better understanding of why the medicine is necessary and what is happening inside their body, that understanding may allow them to be more adherent with the medicine because they understand the importance and the long-term effects that something like a stroke may have. The final component of motivational interviewing is supporting self-efficacy. And this is something that is so important, but actually can be quite challenging to overcome. So in patients, they oftentimes have low self-efficacy, meaning patients don't think they can change, either because they've tried to change in the past and they've failed repeatedly, or they've seen family members or friends struggle with a similar disease state and they've not had good outcomes. So our goal is to use prompt statements to allow the patient to voice changes they've made in the past that they have been successful with. That encourages confidence. So if patients we can show them, you've taken these baby steps, you've made these small changes, and this is some of the effects of that. Here's some of the successes you've had, the goals that you've met. How can we then, again, build that confidence so then they can make additional changes moving forward? Here, I love to use the word baby steps with my patients. So a lot of times patients will say, you're telling me that I have atrial fibrillation and I need to diet and exercise and take all of my medications. And they think they have to make this 180-degree change in their lifestyle between today and tomorrow. And although that would be optimal, it's not doable for the majority of patients, and it sure as heck may not be sustainable. So rather, let's break it down into very small goals. And if we can have them meet small goals each time we see them, it builds that confidence. Additionally, we want to avoid trigger words, so things like diet. So patients hear diet and they initially think diet equals very challenging lifestyle. I don't get to do anything fun. I can't eat what I enjoy. And I failed with my diet numerous times in the past. So rather, we can use other words like, choosing a healthy lifestyle or, adjusting the food intake that we have to, again, to avoid some of those negative connotations that they may have. Here are some examples of self-efficacy that we can consider. So again, if we have a patient that is smoking, we know smoking is problematic for so many different cardiovascular disease states. So a patient might have been smoking 1 pack per day. And when we see them a few months later, now they're still smoking half a pack per day. I have seen, and I've been guilty of this before, saying, you're still smoking, we have to stop. But rather, take a positive approach and say, you've already cut your smoking in half from 1 pack a day to half a pack a day. How did you do that? What did you do to make that change? How are you feeling about that accomplishment? It's still getting the point across that we have some work to do, but it's in a much more positive environment. Another option would be what we see here in the orange is you've lost 5 pounds since our last appointment. How have you made this change to meet this goal, or what changes have you made? So instead of saying, we talked about you losing 20 pounds, you only lost 5, is you're 25% of the way there. That's so fantastic. What can you continue to do to continue to be successful? In addition to motivational interviewing, some terminology that you'll hear is shared decision making, and these really go hand in hand with one another. This is an additional approach that we use to enhance patient success. This is when we work as pharmacists with our patients to make joint decisions together. So we're moving away from that paternalistic or kind of almost like a dictatorship where we're saying, this is what you must do because of the disease that you have. But rather saying, let's take a collaborative approach. Let's explain to the patient the why. Why do they need a diagnostic test? Why do they need a specific medication? Why do they need to come back to the pharmacy or come back to the clinic once a month or once every 3 months? If we can get patients to understand our rationale and have an appreciation for that, they're much more likely to follow up with the recommendations that we're making. Additionally, it's really important to explain the risks versus the benefits of each treatment decision with the patient and take into account the patient's preferences and values as well as their lifestyle. So things like budget, for example. So in regards to a patient with atrial fibrillation, instead of saying you have to be on a blood thinner so you don't have a stroke, here is your prescription for this specific DOAC, rather saying this is what's going on with your body in regards to atrial fibrillation. Because of this blood pooling in your heart, you're likely to get a stroke. Based off of that, we can decrease your risk of stroke by a number of different medications. Here are the options that are out there. These ones are once a day. These ones are twice a day. These are the potential side effects. Feel the patient out to see what is their comfort level and try to meet them halfway. Moving past motivational interviewing and shared decision-making is while we're doing all of this, you cannot forget to take into account the healthcare disparities that patients may be struggling against. So we know that our healthcare disparities are differences in care that patients receive based on inequities. And those inequities are numerous and were discussed in a previous talk that was given. So things that we can do to limit or reduce these disparities is first, improve and enhance our communication using that motivational interviewing and shared decision-making that we've discussed, identifying those barriers to communication and augmenting them appropriately. The other thing is within your institution, use evidence-based algorithms. If there is a protocol or an algorithm that we follow for all patients with nonvalvular atrial fibrillation, assuming patients, of course, don't have contraindications or other issues, that really means every patient is treated as similarly as possible. Again, assuming patient-specific factors are taken into account. So if we use that algorithm or use that protocol, we standardize our care so one patient group is not getting better care than another patient group. Additionally, we can identify patient assistance programs. So whether this is patient assistance programs with transportation to get to their appointments, or patient assistance programs to affording medications that we use to treat atrial fibrillation, those can be really helpful. We want to implement focused efforts in our community. So within the community that you're working in, what are the disparities that you see that are most evident, and targeting reduction in those disparities based on your specific patient population. Based on the disparities that you've identified, we want to train and educate our healthcare providers, because if we as healthcare providers don't understand what a disparity is or how to overcome it, we're unable to care for our patients appropriately. And then finally, the more inclusive we are within our profession as healthcare providers and as pharmacists to include a diverse population of people working for us, the more likely we are to have our patients buy into what we're saying. So again, if a patient sees that there is a pharmacist that came from the same sort of background they came from, that looks like them, that can have a better understanding of where they're coming from, you're much more likely to develop that collaborative relationship and get patient buy-in. So moving on from this, let's talk about how we can do care coordination to further enhance patient care. Care coordination is only a good thing. We know that by care coordination, we enhance patient outcomes, we reduce healthcare utilization, and we lower costs. So we're not doing and undoing interventions or diagnostic tests or education that one provider has provided that we're then having to either redo, or, I'm recommending one thing, a different pharmacist is recommending the other, and we're kind of going back and forth. So we know that by coordinating care, not only within a pharmacy, but within our healthcare system across the board, we enhance patient care. How we can do this is a bit of a challenge. We can organize patient care activities. So again, use the electronic medical record, work with the patient to say, if you're working in a clinic, try to avoid the patients having an appointment 3 days a week, every single week, but rather, can I see the patient in my clinic the same day they see their cardiologist, so the patient is not wasting time having to come to the clinic numerous times a week. In an outpatient pharmacy, can we coordinate a patient's prescriptions to all be filled on the same day every month versus them having to come in 3 to 4 to 5 times? We need to communicate between providers so everyone knows what we're doing. This can be verbal communication, but more importantly, written communication. Because if it's in writing in a patient's chart, that documenting is seen by everyone that reviews the patient's chart. How we can do this, again, we can look at our workflow within our pharmacy. We can also look at what technologies, specifically within our electronic medical records, can enhance this coordination. Other things that we can do in regards to linking our patients with appropriate care. The first thing I ask all of my patients is, what is their budget or what is a reasonable cost to them with medications? It's very easy to recommend a drug, recommend a diagnostic test, and have no thought on, can the patient afford this? This comes back to adherence. Oftentimes we say, patients are not taking their medicines, and we say, oh, they're always forgetting to do it. A lot of times it's not forgetfulness, it's inability to access those therapies. With that budget, again, use your patient's assistance programs, identifying coupon cards that can be helpful. We also want to see what providers will see patients that are uninsured or underinsured, because the medicines are great, but if there's not follow-up to ensure that those medicines are maintaining safety and efficacy, harm can occur for the patient. We want to make sure that patient has follow-up with the adequate providers, and consistently, especially as pharmacists, we should reevaluate treatment decisions. So not only is the medicine safe and effective for the patient, is it still necessary? And maybe it's affordable today, but maybe it's not affordable 2 or 3 months down the road. So let's go back to our patient. So you guys have been introduced to Athena. So as a reminder, she's a 63-year-old Black female presenting to the pharmacy clinic for medication management follow-up visit after seeing her cardiologist. She has hypertension, diabetes, obstructive sleep apnea, hypothyroidism, and today she was diagnosed with atrial fibrillation. Looking at her social history, she smokes a pack a day. She has a diet high in sodium and saturated fats, does not exercise. She misses doses of her medicines multiple times a week, and she has insurance, but unfortunately there are high premiums and high copays. She's on a large number of medications that are listed for you here to treat all of these disease states, and we have more medicines we have to add based on this new diagnosis of atrial fibrillation. Her blood pressure and heart rate are high, and we did the newest vital sign, which had a score of 3, which tells us that she has a limited health literacy level. Lab values are normal except that her blood sugar and A1C are elevated, and her ECG shows atrial fibrillation. We calculated a CHA2DS2-VASc score for this patient, and it is 3. Her HAS-BLOOD score is 1. This helps us to identify that she is a candidate for anticoagulation because her CHA2DS2-VASc score is 3 or higher. And it does call into question that she does have this bleed risk of aspirin, so we need to reevaluate the use of aspirin for this patient. Based on this information, it's determined that she will be started on metoprolol succinate 50 milligrams once a day for rate control and apixaban 5 milligrams twice a day for stroke prevention. So when interviewing or meeting with this patient, we'll use our motivational interviewing, we'll use our shared decision making, but what information should we gather? So here we need to try to understand, what does the patient understand about their diagnosis of atrial fibrillation? What do they understand about the necessary treatments for this disease state? Do they understand why they need to have follow-up appointments? What has their experience been thus far with not only atrial fibrillation, but other disease states and treatments that they've taken? And then let's look at, why is she not adherent? We see that she's missing doses multiple times a week. Why is this occurring? So something that we've done with the patient thus far in this visit is we've talked to her about what atrial fibrillation is. We've discussed with her the potential complications. Let's go ahead and move into our first video to see how we can converse with this patient to start. So now that we've chatted about what atrial fibrillation is, what questions do you have before we move on?
Well, can you tell me more about these medications that I'm supposed to be taking?
Absolutely. So I see here that you have 2 prescriptions that were written by your cardiologist for the abnormal heartbeat, which is the atrial fibrillation. The first is metoprolol. The second is apixaban. Are you familiar with these medications?
No.
Okay.
No.
So let's take some time talking about what they're used for. So as I mentioned before, atrial fibrillation is when your heart beats too fast. Metoprolol is a medicine used to slow your heart rate down. If we slow your heart rate down consistently, that can prevent you from developing that scary complication of heart failure. Apixaban is a blood thinner. This medication prevents you from developing a stroke, which you're at risk at because of the abnormal heart rhythm. So based off of that, what questions or concerns do you have?
I already take the baby aspirin. That should be good enough.
So that's a great question. So people will call baby aspirin a blood thinner. It works a bit differently than the apixaban works. And we found that aspirin is not as effective. It doesn't work as well as apixaban does at preventing strokes. So what we would do is we would stop the baby aspirin and use the apixaban instead.
Okay.
What other concerns do you have?
Cost. Good baby aspirin fits a little better into the budget. I don't know about what you said.
Absolutely. So I definitely want to make sure that we are always respectful of your budget, as well as, the burden of having to take these medications on a daily basis. So something that I've been doing some research into are coupon programs. I know that this medication is more expensive with your insurance. So I'd like to talk to you about some patient assistance programs that can help decrease that copay on a monthly basis. Would that be okay?
Yeah.
Okay, great. All right. So as you can see, we used our motivational interviewing, our shared decision making. We used some of those tips to gather information, those open-ended questions, checking in with the patient's understanding, using some of those summary statements to gather more information. So next steps is, again, further using motivational interviewing to get patient buy-in to moving forward with treating her atrial fibrillation. We want to identify strategies that can improve patient adherence. We want to identify coupon and assistance programs that we can use for the patient. We also need to be cognizant of her potential lower health literacy and speaking to her on a level that she can understand. So other things that we've considered thus far, the pharmacist has looked into costs of the medication as well as research some patient assistance programs. So let's take a look at our second video to see how we can further advance the care for this patient. Well, it seems like the metoprolol is very doable for your budget, which I am happy to hear. The apixaban seems to be the drug that is causing us a bit more trouble due to that higher tiered copay. So I wanted to work with you to get this much more affordable for you. So unfortunately, all of the medications that are similar to apixaban are of similar costs. So, switching agents isn't really going to be helpful. However, apixaban does offer a patient's assistance program that's pretty easy to use and easy to get a hold of. I worked with the pharmacy that's filling the prescription for you, and they have processed that coupon that the drug manufacturer offers in addition to your insurance. And that brings the copay down to $10 a month rather than that much higher price. How does that sound in regards to your budget?
Well, 10 is much better than that original price. Yeah, I guess, we can try that.
Okay. Well, how about this? So, I want to make sure that we're always respectful of your budget and your lifestyle, not just today, but moving forward. So we do have a follow-up appointment in 2 months for you to come see me again. Let's reevaluate at that point in time and see if that $10 a month is still conducive to your budget. And if not, we can make adjustments at that time. Does that seem okay?
Yeah, that would work. I appreciate that.
Absolutely. My pleasure. The other thing I wanted to talk about is I was looking through your prescription profile and I noticed that some of the refills were a bit delayed and when you picked them up from the pharmacy. What struggles are causing you to not be able to pick your prescriptions up on time?
It could be any number of things because I work full time and I'm the sole caregiver for my mom. So in between doing those two things and just whatever else comes up, I don't always get around to it. It just falls by the wayside. In addition to sometimes my money's just not right. So it could be a combination of things.
Okay. Well, thank you so much for sharing. I really appreciate that. Something I wanted to offer to you as well is when working with your pharmacy, I did notice that they offer free mail order for prescriptions. And this would include the 2 new medications that we would be starting today. That is free of charge and they mail them directly to your door each month. You're on an auto refill program. How does that fit into your lifestyle?
Oh, well, front door delivery sounds pretty convenient.
Okay. Well, how about I'll give the pharmacy a call after we end our visit today. I can get you set up on the auto refills, make sure that coupon program goes through okay. So you do have that lower copay. And then I'll give you a call later this afternoon to update you on when to expect those prescriptions to be delivered. How does that sound?
I think that sounds okay. Willing to give it a try.
Thank you. Well, what other questions or concerns do you have?
I can't think of anything right now.
All right. Well, thank you so much, Ms. Hubbard, for your time. I really appreciate everything that you've shared today. My contact information will be in the discharge paperwork you receive after our visit today. Please use that number to call me anytime. And if not before, I look forward to seeing you in a couple of months.
Thank you.
Thank you. Okay, so my hope is that that video provides you with an example of what a conversation can look like with a patient that we can use to really enhance patient care. Now, of course, every patient interaction is going to be different and will have to be adjusted based off of what you learn from the patient and what levels of resistance that you come across.
Thank you very much, Dr. Lusk, and thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.